I too want to I'm very grateful to be here and really thank the organizers for this incredible um, uh, conference and to be part of this. I really will be very brief. So I just wanted you to know that I'm tasked to give you maybe some examples of some clinically impactful papers that have come out in the last year or so. And my disclosure again are that these slides are courtesy of AASLD, and particularly they are actually modified from the clinical sessions that were given by the editors of hepatology. And so just so that you know, I took their slides. I will say that we only did the clinical part. There's also basic science research that gets published in these journals. So I had highlighted it because, I thought that for this audience, perhaps the clinical articles were more pertinent. But just so that you know, our journals publish a lot of basic science as well. So with the first paper, this is just a review. You all know this already with the practice guidance on portal hypertension, that, we recognize the no cirrhosis, compensated cirrhosis, and decompensated cirrhosis. But I think just to highlight the idea that we're actually favoring carvedilol because of its alpha adrenergic blockade as a preferred non-selective beta blocker for anyone with clinically significant portal hypertension. And so really many of us are doing a lot less endoscopy. We're using a lot of non-invasives as well as obviously if they have symptoms. But one thing that you may or may not recognize is that carvedilol is actually probably more effective than propranolol. And in our country, it can be, the original trials where carvedilol were done as a once-a-day dose, even though it's not the long-acting. And in our country, sometimes you don't have access to long-acting propranolol, so it's actually very convenient. We recommend a much lower dose than what they were using previously, so 6.25 to 12.5 milligrams a day, preferably 12.5 if they can achieve that. But it can be given as a once-a-day dose, even as a short-acting medication, just so that you're aware. Now, first paper is the hemodynamic effects of carvedilol plus simvastatin. I think there was some presentation by others who have said that, there is this role of simvastatin perhaps in cirrhosis and severe portal hypertension, particularly those with suboptimal response to beta blockers. And this was a double-blind placebo-controlled randomized trial. And so in this study, just to review, statins have actually been shown to improve survival and hepatic decompensation. It has pleiotropic effects on the endothelial dysfunction, intrahepatic vascular resistance, and decreased oxidative stress and inflammation. And in this study, patients with severe portal hypertension and high-risk varices or without previous bleeding underwent a baseline hemodynamic study. And was given treatment, and subsequently if they were found to be non-responders to propranolol, they were then randomized to either placebo or simvastatin with carvedilol. Everybody got carvedilol. They were then given either placebo or simvastatin. And then they did a second hemodynamic study. And what was really interesting was that after 4 to 6 weeks with carvedilol and simvastatin, there was a significant decrease in the hepatic vein portal gradient. And this was even also noted that a blunted response to the hepatic vein gradient increase after a liquid meal. So the summary was that the addition of simvastatin to carvedilol significantly reduced hepatic vein pressure gradient compared to just carvedilol alone, and prevention of hepatic decompensation could perhaps meaningfully reduce the burden on the cost and healthcare system. So it's something to think about, that the addition of simvastatin to carvedilol may decrease portal vein pressure gradient. This one has already been discussed by Dr. Ashwani, but I think it has a lot of impact and really thoughtful of the reversing malnutrition. We're always looking for a treatment, right? Like we know sarcopenia is important, but how do we treat it? And this is the study that he had mentioned with targeted enteral nutrition in patients awaiting for liver transplants, randomized controlled trial. And this was 57 patients who had high MELDs of 22 to 25, of course, predominantly child's TRCOP-C since they were pre-transplant. And they were also graded to be very nutritionally deficient. And he has shown this graph to you that they were given nighttime enteral feeding. The remainder of, the other ones got standard of care. They were told you need to have more protein. It was like 50 grams per kilogram. So they were told you need to have this, right? So the thing that I saw here was that you can see that basically this graph doesn't so much say it, but what the paper said was essentially, you can tell them all you want, you can get dietitian and everything, but everyone who was in the they never achieved their goal of 15 grams per day, per kilogram. So like you really needed something other than just telling patients you need to eat high protein. So I thought that was interesting. And of course the outcomes showed the difference. And in other words, 100% met their daily needs in the enteral feeding group, but none, essentially not that many. I do not believe anyone did in the other group. Here, you can see that the outcome was hand grip, as well as other measurements they did, like arm and things like that. But you can see that there was a really significant improvement in mid-upper arm circumference, and body weight and hand grip. And I think this is really important because it really showed that even short term, you could potentially, there's actually an intervention. So supplemental nocturnal enteral feeding really improved nutritional intake, as well as really objective measurements of hand grip and body anthropometrics. So I think it's a promising thought for those of you who are hoping to have something to do with your patients that would actually make a difference. The other one I wanted to highlight, like we don't just do we don't just publish randomized controlled trials, but we also do large data analysis. And this was a retrospective large data analysis of renin-angiotensin-aldosterone system inhibitors in clinical outcomes of patients with MASLD. And it was a target trial emulation with real world data. And here, what they did was they used a large database. This is a database of like 88 institutions, and they collected data, and this was a retrospective study. Basically, they compared patients who were diagnosed with MASLD and was placed on ACE inhibitors, ARBs, versus calcium channel blockers. And you can see that the numbers are quite large. They tried to do this comparison by using propensity score matching to match the cohorts. And this study showed that essentially, if you did sensitivity analysis on different characteristics, in all these cases, ARB and ACE, in fact, in almost all of them, was significantly better in terms of predicting all-cause mortality. So, by different categories of patients, you could see that this was consistent, and as well as with major liver outcomes, and so versus calcium channel blockers. So after the propensity matching, you can see that, those patients who were on ACE and ARB had a decreased hazard ratio for major liver outcomes, as well as cardiovascular outcome, and of course, all-cause mortality. And you can see the numbers of the decrease in hazard ratio. So ACE and ARB use in patients with MASLD was associated with reduced mortality, major adverse liver outcomes, and major adverse cardiac outcome. Obviously, this is a retrospective study and may prompt us to do a prospective study. The last but not least is other things I think people have mentioned a lot about. This was also already discussed by Dr. Norden. So basically, this is the semaglutide therapy for MASLD. As you know, we publish a lot of the guidances and guidelines within AASLD Journal Hepatology. And I don't need to probably go into this in much detail, but as you know, the phase 3 interim analysis of the ESSENCE trial was presented, and that's how we got early FDA, what do you call that? But, interim FDA approval so that this drug is now available. But in the United States, patients on clinical trials may be willing to undergo a liver biopsy, but for a clinician, I don't know, what is it? Maybe the way I explain it, no patients will undergo a liver biopsy. And so this was a particularly useful guidance, and they use the data, sorry. I think I'm going the wrong way. Well, can I go back? Oh, sorry about that. Yeah. So they basically use the data from the trials because these patients got both biopsy and many of these non-invasive markers to give guidance to the field on how to use this. And this is particularly helpful for us because many of us, these are expensive drugs. And if you don't have this guidance, the insurance company won't cover it. And so many of this is really to give guidance using non-invasives. And these tables are very helpful. We did the same thing with the resmetirom, and this is with semaglutide. And I think it can be very useful to the field in order to kind of give you some guidance about how to use non-invasives to put patients on semaglutide. All right. But last but not least, the key points were statins can have incremental effects on portal hypertension. Targeted enteral feeding can have significant impact on sarcopenia. ACE and ARB was associated with improved outcomes in patients with AASLD. And we hope that the AASLD guidance can help clinicians when using semaglutide in at-risk MASH without a liver biopsy. So thank you.